Hey everybody, my name is Alex Smith, and this is my technical article summary presentation for APT 410. Now, the subject of today's presentation is going to be an article written in 2019 for the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine. The authors of this specific journal article are, and I apologize if I mispronounce any names as these are Scandinavian names, they are C. Moshman, E. Hepson, A. M. Rubin, and C. Barford. Now, the title of this specific article is New Clinical Guidelines on the Spinal Stabilization of Adult Trauma Patients, Consistent and Evidence-Based. And again, like I said, this was published in 2019. So the purpose of this article is to address some of the underlying issues and the possible lack of evidence associated with the use of specific intervention devices for traumatic patients. These include the use of so-called long spine boards, which I'll abbreviate to LSB, vacuum mattresses, and rigid cervical collars. To make this a little bit more simple to understand, I'm sure most people who have seen EMS shows, movies, anything of that nature, you have seen patients that have been strapped down to these long plastic boards. That is a long spine board. And if you've ever seen someone who has had a neck injury, you see the rigid collar that goes around their neck. That's the type of collar that I'm referring to. And a vacuum mattress is basically the same concept as a long spine board, but it uses air inflated into a large device, which is then used to secure that patient into a inline position. So the issues examined by this paper are very interesting in the context of EMS. So EMS has been around for a fairly short period of time, and I won't get into a lot of the history involved with it, but a lot of what has occurred in EMS and the treatments used and the various types of interventions used, these have began a long time ago, but haven't necessarily progressed over time. So this specific journal entry, this covers cases specific to Denmark, but it also covers a lot of different international bodies of science that also relate to EMS all over the world. So while it's maybe specific to Denmark, it does apply to EMS as a whole. So the specific injury discussed in this regard are traumatic spinal cord injuries, or TSCIs. They are very rare types of injuries for people to sustain, even in traumatic events like car accidents or major falls. They're very, very rare. But according to these authors, for decades, pre-hospital treatments have focused on securing patients with any possible sign of injury of the neck or the spine, securing these patients with neck collars and long spine boards. However, it seems, especially according to these authors here, and over time as the evidence has been examined, that there really hasn't been any evidence to support this kind of routine use. It's been done for years and years and years, but where's the evidence to support their use? So that's the subject of what this paper was written for. Ultimately, as a result of the evidence gathered throughout this paper, the work of these authors, the research, the medical experts interviewed, and everything else, the conclusion was that they came up with 5 different recommendations regarding spinal stabilization techniques for any kind of patient with traumatic events. We'll discuss those more in detail later on, but ultimately they came up with a strong recommendation against routine spinal immobilization of her patients with isolating penetrating trauma. So for instance, if somebody's in a car accident, but they have an isolated penetrating trauma like a piece of metal or something like that to their chest or their leg or something of that nature, the conclusion of the evidence in this article shows that there is a strong recommendation against stabilizing somebody with a full spine board neck collar in that instance. Now, they also came up with weak recommendations against the use of pre-hospital routine stabilization for patients that are ABCDE stable. What that means is patients who have no issues with their airway, no issues with their cardiac function, no disabilities, no exposures, no issues with their breathing or anything else like that. Basically, a patient that is able to walk around following a car accident, major fall, anything like that, they issued a weak recommendation against the routine use of these interventions. They also issued a weak recommendation for the use of a vacuum mattress for patient transportation. And then finally, they also instituted several algorithms that they hope will be used by EMS providers to ensure better clinical practice for these types of patients. So, to start off there with our methodology of this whole thing, the very beginning of the paper covers 2 major studies that were included in the initial body of evidence for this paper. They were both done at hospitals. One was in the University of New Mexico in the United States, and one was in the University of Malaya in Malaysia. Now, what they did was they compared 2 sets of patients. One set of patients, which was 120 different patients at the University of Malaya, and none of these patients underwent any kind of spinal stabilization during patient transport. However, when they compared them to the 334 patients in a separate study at the University of New Mexico that did undergo a routine spinal stabilization or immobilization during transport, they found a rather odd distinction between those two, a disparity that was really somewhat concerning. So what they found out was that there were far fewer neurological disabilities sustained in the Malaysian patients than in the ones in the United States. What that basically meant was that the 120 patients seen at the University of Malaya, they had no significant neurological dysfunction as a result of not having the full spine board neck collar stabilization treatment. Whereas the ones at the University of New Mexico had a higher chance that they would have that type of an issue. So in a separate study that they included as well in the beginning of this paper, is they covered an analysis of trauma patients that were included as far in data in the United States National Trauma Data Bank. They covered 45,000 cases. And what they found is that the results show that only 0.01% of patients in the 45,000 trauma cases had an incomplete spinal cord injury and underwent any kind of surgical spinal fix or spinal repair. So what that basically means is out of 45,000 cases of traumatic events, less than half of 1% of these patients had any kind of a spinal cord injury that one would imagine would necessitate the use of a long spine board and a cervical neck collar. And what they found was basically that, according to that study, just in of itself, EMS providers were over-treating patients with these spine boards and these neck collars, which in of itself is something that was concerned, but it basically lays the groundwork for the rest of the paper overall. So the specific methodology they go into following these two primary studies is pretty smart. It's a very good approach to this type of an issue. They covered a systematic review of all the literature relating to anything to do with spinal immobilization, spinal trauma, or anything else relating to any of that kind of thing. Then what they did was, with the help of expert researchers and medical personnel, they graded all this evidence based on the quality of evidence, their own clinical judgments, and they had a consensus process they used to kind of determine what was the best papers, the best works they could use to include into their body of evidence. So what they basically did is they went to the ground level on this, and they covered everything that had been covered up to that point, from the early years of EMS up to the modern times, to say, hey, what is the actual evidence that we can find for or against any type of immobilization technique in EMS? In addition to all that, they also created a task force, which was comprised of 8 different medical associates in Denmark, representatives from the Danish PHTLS, which is pre-hospital trauma life support, they had ITLS, ATLS, and numerous other internationally recognized, including the United States, traumatic systems of protocols and training that basically every paramedic provider goes through. This is something that is standardized quite well from the military to the civilian world, and it puts everybody on an even plane. So they had representatives from these services. They had medical directors from the largest Danish EMS services and ambulance providers around, and they also included 2 research methodologists. So they defined the scope of this whole thing, so they kind of keep their focus narrowed as much as possible. But they had a set of criteria they used to determine what was the scope of each paper they wanted to cover. And then they had a target population, which in this case they chose trauma patients ages of 18 years and older. Now there's a slight issue here because they didn't cover traumatic patients younger than 18, so pediatric traumas, that this evidence listed in this paper, this article, might not be applied that well necessarily to pediatric patients. However, it does apply fully to ages 18 and older, which is still the most common population EMS providers will run into. Moving on from that, they did a search of all the guidelines from international resources, Australia, different places in Europe and everywhere else, that would give them an idea what the actual guidelines were in all these different countries for current treatments for traumatic spinal cord injuries. Basically, the idea was that they gathered all the evidence that they could regarding spinal trauma and spinal immobilization techniques, and then they compared it in some ways to what the current guidelines were. They said, hey, what do the current guidelines say to paramedic and EMS providers in general out there, and what does the evidence actually show? That way they had a control group, they had a way of comparing their evidence to what paramedics and EMTs and other providers were doing in the field in that point in time. There were some things they also excluded. They excluded randomized controlled studies. They excluded large observational studies, and they got rid of a lot of different things with like cadavers and case reports and things like that that were a little bit too biased towards individual situations, not necessarily like a large scale, broad study. They were looking more for that large scale study that would give them as much data as possible, and not so much the anecdotal evidence that a specific provider may report in a run report or something of that nature. So in total, the results of their work were as follows. They had a total of 6,484 titles and abstracts that were identified in their review. They had some other pieces of evidence as well that were combined, but basically they covered the length and breadth of all available knowledge throughout most of the world regarding EMS's use of spinal immobilization techniques in reference to traumatic events leading to possible spinal cord injury or secondary spinal injury. So what they did was, as a result of their accumulation of evidence and their assessment of the evidence, they came up with 5 different clinical questions. And what they did with these 5 clinical questions, they tried to answer these questions with the evidence that they were presented with and that they found as it worked. So the first question they asked was, should adult trauma patients with a risk of a secondary spinal cord injury undergo spinal stabilization with a rigid cervical collar, the hard collar that people wear around their necks when they're injured? So what they came up with was that there was a weak recommendation against the use of rigid cervical collars. And the reason why was because they could find no good high-quality studies showing efficacy at all for its use, meaning that for years and years and years, EMS has put people in these hard collars over and over again without good evidence showing that this does anything helpful for patients. Excuse me. The repercussions of this are pretty significant, as you can probably imagine. There are negative effects associated with use of these types of collars, which they cover as well in answering their own clinical question. You have decreased lung function, longer ER stays. You have impeded airway function because when you have that hard collar around your neck, it's difficult for a provider to get access to your airway, their ability to assess and treat you, intubation tubes, things of that nature, suction. All of that is decreased when you have that hard collar around your neck. But people have treated that for years, and yet somehow the evidence does not support its use. So their recommendation was a weak recommendation against the routine use of these types of collars. So the second clinical question they asked was, should adult trauma patients with a risk of a secondary spinal cord injury, in other words, trauma patients who have the risk of moving, shifting, or doing anything else that would cause a secondary injury, should they undergo spinal stabilization on a long spine board, that long, hard plastic backboard? So their recommendation, as it came to their conclusion as a result of the evidence they had, was that there was a weak recommendation against the use of a hard backboard as a spinal stabilization measure. And specifically in the case, as I said before, A, B, C, D, E stable patients, meaning patients who are vitally stable, they can breathe, talk, move around. So in other words, a person who's been a victim of a car accident, if they climb out of the car, they're walking around, there is a recommendation that those patients not have a long spine board ply and they not be restrained on that. The third clinical question covered was, should adult patients with a risk of secondary spinal cord injury undergo spinal stabilization on a vacuum mattress, which is, again, is a soft blow-up type mattress, and that's not the hard, rigid spine board, so it's a little bit different of an effect when it comes to its implementation. So what they found was that there was not a lot of high studies regarding its use. However, they also didn't find any specific negatives associated with it. So their conclusion with that was a weak recommendation supporting its use for patients. If spinal stabilization and mobilization is necessary, the vacuum mattress is a better tool than the long spine board. So the fourth clinical question they asked was, should patients with isolating penetrating trauma undergo spinal stabilization? So an isolating penetrating trauma is, like, as I said before, you're in a car wreck, part of the car stabs through your chest, causes significant injury there, your leg, your side, anything else. It's a focused injury. It doesn't necessarily involve your whole body. What they discovered was that not only was there significant evidence against that, but the use of that type of a device, long spine board, spinal stabilization, was doubling the effective mortality rates of these patients. And the reason why is a lot of times in these significant major traumatic events, these patients need immediate effective care. So paramedic providers, because in their protocols, they generally treat the spinal stabilization and life threats initially, it takes so long to stabilize somebody on a long spine board and the cervical collar and everything else, that large bleeds, breathing issues, and other physical problems that need treatment quickly are not being handled as quickly as they should have. And that was leading to increased mortality in these patients. So their recommendation was a very strong recommendation against using long spine boards and cervical collars in patients with these kinds of situations. Unstable patients with focus injuries like that basically require treatment for those injuries first, and then spinal stabilization techniques later on that are appropriate for that type of setting. The fifth question they asked was, should the decision whether and how to perform spinal stabilization on an adult trauma patient be facilitated by a clinical triaging tool? Basically what they mean is that should that decision be something that is decided by a standardized triaging tool, or just case-by-case basis? And what they basically came to the conclusion was that there's not really any specific evidence showing for or against that, but the thing with EMS is that it runs on protocols. Paramedics, EMTs, they are not necessarily healthcare practitioners of sorts. They are providers that operate under the medical license of an actual doctor, and they operate based on protocols. So like anyone basically less than a doctor would, they operate based on protocols. So their general recommendation was it would be a good practice to give paramedics, EMTs, and other providers a set of protocols to follow that would allow them to nullify the need for any kind of spinal stabilization based on certain criteria. This is catching on more and more throughout the United States. The idea of clearing people from spinal immobilization, great concept, but this piece of paper basically supports it as a best practice. It's one of those things that doesn't hurt. It would be the best thing to do. It's not necessarily recommended or required, because evidence is not going to show that one way or another, but it would be a good move in the right direction. So ultimately, as a result of this paper, they found that the evidence for spinal stabilization in trauma patients as a routine habit is, in their words, sparse. They did a full systematic review of the evidence. They basically covered everything that anyone could have covered regarding this, and they were unable to come up with any significant evidence indicating the widespread use of these types of techniques as good. In fact, they came up with many different studies and things that would really lead to indicate that these types of techniques are harmful and can lead to worse patient outcomes and further injury. So that's kind of the thing with EMS, is that you have a system and a functioning medical system right now that is fairly new. It's not like the nursing practitioners or nurses in general or anything like that. It's not something that's been around for a very long time. It's grown quite quickly, and it's become quite a common thing today. But the techniques and the practices that have been used over time, some of these things have been in place for many years without necessarily any evidence to support its use. It's one of those things where it's just because, so that's the way they've always done it, the way we always will do it. It's just common knowledge. When you go back and you look at it, you realize that you're harming patients as a result. My own personal opinion on this paper, as a result, as someone who has worked as a paramedic, to give you a little bit of background on myself briefly, I have been a paramedic for about 6 years now. I worked on an ambulance at 2 different services for about I think it was since 2014. I've been EMS since 2013, and I've been a paramedic since 2014. And I've seen these techniques used quite frequently, but it's only been the past couple of years, maybe last year, that the idea of even thinking about bypassing a spinal immobilization technique has even come to fruition and been inserted in the normal state or national protocols. So it's something that's pretty close to me. It's something that's very concerning to me when it comes to how we treat our patients, because ultimately it's all about the patient and how well we treat them and how well we can improve their outcome after treatment has been accomplished. So ultimately, I think they did a great job in this paper. The authors did a very thorough clinical review of all the evidence that was available, and the conclusions that they came to are, in my opinion, and from what I know based on my training experience as a paramedic, their conclusions are supported by fact, and the specific recommendations they make have become more accepted over time with EMS providers, not only all over the United States, but all over the world in general. So thank you very much for watching this video. I'll see you in the next one, and have a great night.